So graded your papers. Great job. Everybody did well. I didn't grade them too hard. One comment I gave to a number of you was, and I don't know how much of it was you just weren't trying very hard on the essay or not. But when you write an essay, right, of this sort, just relatively simple 5-paragraph style essay, you do an introduction, some sort of, like, the person I'm talking about is Bob Jones. You know, Bob Jones is a brilliant CEO of someplace, blah, blah, blah. I'd like to tell you 3 things about Bob Jones. Paragraph 1, here's thing 1. Paragraph 2, here's thing 2. Paragraph 3, here's thing 3. Conclusion: Bob Jones is a brilliant, CEO, and I've told you these 3 things about him. End. Right. If you can do that consistently, that makes your writing much easier to read. The main criticism that I gave to a number of you was, instead of having, like, I'm going to talk about Bob Jones, you then had this really long, page-long paragraph where you talked about a bunch of different things about Bob Jones, and then you had a conclusion. It's important to use paragraphing. So that's my point here is you use paragraphing, right, to capture single ideas, or collect, or ideas that kind of follow a single theme. So I want to tell you about Bob Jones' early career, right? One of the things I asked you to do. So that would be a good paragraph. Then I asked you to say something about Bob Jones's current organization. That would be a good second paragraph, right? And then, you'd have a third paragraph, and then you have your little conclusion about whether you like, would want to be Bob Jones or not. That was that particular essay. When you go to take the GRE, right, which most of you will, or the GRE or the GMAT, there is a written component of the GRE and the GMAT, or at least there used to be. I think there still is. And you're required to write 2 essays. One of them is a standard 5-paragraph essay of the sort I just described. And if you can follow that format, I'm going to tell you about and they'll give you a prompt, and you have literally like 20 minutes to write a 500-word essay. They'll give you a prompt like, why is bacon the best food in the world? And you have to then come up with, and the way to be successful with that is to say, bacon is the best food in the world for these 3 reasons, blah, 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 blah. Let me tell you more about each of these 3 reasons. Paragraph 1, reason 1, paragraph 2, reason 2, paragraph 3, reason 3. In conclusion, I've told you about how great bacon is. It's a skill you want to build because it enables you to communicate more succinctly and more clearly. If you tell me in your introductory paragraph, I'm going to tell you these three things, that's a very useful way of setting up your paper for success. So I'm going to tell you about bacon. Here's the 3 reasons why bacon is wonderful. And then each of the supporting paragraphs, you add, you add detail to your kind of introduction. That works really well because the reader you've told the reader, I'm going to tell you these 3 things. Then you tell them, here's thing 1, here's thing 2, here's thing 3, and then you conclude with some sort of conclusion. I've always found the conclusion is the hardest part to write. But if you follow that format, what you've done is you've set up your paper so I know what's coming, and then I can follow it. Now, this paper doesn't necessarily follow quite that. It wasn't that loose. I gave you some fairly specific things I wanted you to write. But reading some of you need to pay more attention to paragraphing in particular, with the idea that you want to consolidate ideas into paragraphs so that a paragraph covers a particular set of ideas. That helps the reader follow your argument. Okay, and that is going to make you more effective. And I'm just putting that out. I don't think you're writing anything more for me, but as you go forward, a number of my other classes, I have students writing papers, a lot of papers, and I really rehash that format over and over again. And it's something you probably learned in like 5th grade, right? And we learn it in 5th grade because it's effective, it works. And it's useful in business. If you can think and organize your thoughts that way, if your writing is organized such that you tell people what you're going to tell them, and then you tell them the stuff, and then you tell them what you told them, you're going to be more effective as a communicator. And being effective, an effective written communicator in today's world is is incredibly important, because when you go out into your future roles, you will most likely be communicating with colleagues, bosses, and clients via email, right? And so you really want to work on your written clarity. Okay, so just a little bit of feedback. Everybody did fine, but just a little bit of feedback on that. So if I commented on your thing and said, hey, you really ought to think about paragraphing because you had a 400-word paragraph, an introduction, a 400-word paragraph, and then a conclusion, you really want to work on thinking about how your paper is organized. All right, so that's enough about that. I did enjoy reading the papers. I'm glad, I'm glad you, most of you seem to find the people you talked about interesting. Because so many of you talked about Eileen, there were like 7 of you that did Eileen Keefe. I have invited her to Zoom into our class on Thursday. For those of you who didn't do Eileen, she's the chief nurse for Parkland Medical Center in Derry. And she is a 2-time UNH grad. She's got her master's and now her doctor of nursing practice from UNH. So she's going to Zoom in for about 20 minutes on Thursday to talk about nursing, because that's an important part of what we'll be talking about for this chapter. So inpatient care is the chapter we'll be doing. So we talked about outpatient care, and we talked about how care, most care happened in the home, right? Then through the 20th century, as we became more industrialized and technology, and medical technology actually started to work, right? But it became very expensive. We started to see a consolidation into the hospital as kind of the hub of the medical system. And now, as technology has fallen in cost and insurance has worked to find cheaper ways to provide care, this combination has seen kind of a boomerang effect, or I called it there and back again, right? Where we're bringing care back out into the field. That's not to say that inpatient care isn't still incredibly important. It absolutely is. We're just seeing, we saw, almost no inpatient care to almost all inpatient care to, we're kind of zooming back to much less inpatient care than we had. And the important things to think about there is the change from in the way that our reimbursement has been done, right? We had cost plus reimbursement, where we just paid whatever the hospital just tell us how much the cost was, we'll pay it, to, hey, hospital, we're going to pay you a fixed fee, right? A prospective payment, right? That hey, if you come in with a DRG for pecked by a turkey, right, we're only going to pay so much, or sucked into a jet engine, we're only going to pay so much based on the DRG, right? And the result was a reduction in inpatient care. So that said, what's left in inpatient care is becoming more and more critical, right? So what happens on the at the inpatient level is the most intensive care required. So let's, I'm going to hit this. All right, we've done this hockey stick of growth before, but I want to bring it back again because it is really important for the way I think about it, right? So let's just rehash this, right? So going way back in history, so the bottom line is years, right? So going back to the year 1000 and coming forward to this is 2016, right? And then GDP per capita, right? So the amount of income that we had per capita, we were poor and on the verge of starvation. The average human being in the world existed at the edge of starvation from before time, right? So from, we've been walking around, Homo sapiens have been running around on the earth for about 200,000 years. So going back to when we were hunter-gatherers, up until, relatively recently, the vast majority of human beings were living on the edge of starvation. We were poor, we were violent. If you were a caveman, you had something, prehistorical caveman, there's a lot of kind of, oh, everybody was back in the nature and we were all picking flowers, and no, actually, there's good historical evidence that kind of prehistorical man living in caves regularly went to war with each other over resources. There was a very high probability that you would be killed by an invading clan or tribe, especially if climate shifted, right? Because you were already through most of human history, we carried no resources year over year. The idea of storing food year over year was a thing that happened about 10,000 years ago. So for the first 190,000 years or so, we ate what was available. And if we had bad weather or something, we starved, or we went and killed somebody, another tribe, and took their stuff and maybe ate them in the process. So that was prehistory, right? And then we come up to, the 1800s, and we see, or the late 1700s, and we see a change. So let me just cover so we had, so from a healthcare perspective, so we had kind of this traditional period, pre-industrial period, up through the early 1400s. We had the Renaissance, which is a rediscovery, right? Renaissance means rebirth. So a rediscovery of classical learning. So you had the collapse of the Roman Empire around 300 AD. I mean, it kind of depends. The Romans were perhaps the greatest engineering culture ever, including our own, I would say, considering where they started from. And we lost all that, and we went into a culture of tradition, maintaining tradition. And we just tried to kind of sustain, but we didn't engage in science. This idea of science, of testing hypotheses, we didn't do that, right? We read the Bible, and we took literally things in the Bible, and we assumed that the Bible was the source of truth, right? The Renaissance was a rediscovery of classical learning. So through it was very interesting. The Islamic Empire actually saved a lot of classical Greek and classical Roman stuff, was translated into Arabic, and then and preserved, and then it was brought back to Europe during the Renaissance, and people started, bringing it back into Latin and bring it back into Greek, and reading the original texts and saying, oh wow, these Roman and Greek guys were doing math, and they were testing hypotheses and stuff like that. And all of a sudden there was some changes, the Renaissance and exploration of these ideas changed the way we thought about learning. And gradually that shifted into the Enlightenment, where we started to abandon tradition, saying, maybe the Bible isn't, all the truth that we need. We can actually apply reason to the world. And it was the Enlightenment that kicks off the Industrial Revolution, which creates the hockey stick of growth that we've talked about before, where we see this incredible spike where people suddenly aren't living at the edge of starvation, or so fewer and fewer people were living at the edge of starvation. I'm telling this story a second time because it's so important to understanding the world, but it's also important to understand and to place healthcare and the evolutions of healthcare in their appropriate place. So we've talked a little, and so this is a little bit of a review, right? So we have, prior to the Enlightenment, in most primitive cultures, we had very primitive, undifferentiated institutions of social welfare. So we've talked about almshouses, right? We didn't have hospitals where healthcare specifically was delivered. We had these institutions for the poor or the indigent. And so they were kind of undifferentiated in the sense that, like, you went there because you were poor, you went there because you were sick, whatever, it didn't matter. It was all kind of one thing, where the handful of rich people in your community got social status by providing support to the poor, right? Then as we started to get wealthier, we see a beginning of differentiation to where we had institutions specifically for the sick, and other kinds of social support institutions. So we started to separate out, actual hospitals versus just places where you dumped people who didn't have family to take care of them, right? In that time, we also start to see the application of science to medicine. So we've talked about things like, germ theory. We've talked about, aseptic technique. We talked about Semmelweis and like starting to apply observation and reasoning to the way we provided care. So kind of pre-Renaissance up through the mid 1800s, we were still relying on that, ancient Greek theories of the humors and all that, bleeding people when they had fevers and other stuff that today we would, look at as nonsense. That's kind of coming out of tradition, right? And it wasn't until we started into the Enlightenment and started to apply reason and science to everything that we started to see real evolution of and quality of care. So we started to see, again, through the 1800s, organized medical institutions. So we saw the actual implementation of actual hospitals. We saw the beginnings of the professionalization of medicine. And importantly, we'll talk about nursing today. And nursing is very focused on providing the environment of care, right? And executing effectively the directions of physicians in an institutional setting. Though they actually, I'll talk about this in a minute, they actually, as nurse, but nursing, right? Nursing, we've had nursing in a very loose sense forever, right? Nursing at its core is taking care of somebody, right? With compassion and empathy and skill. So we've had that forever, but it was just your grandmother would do that, or your, or some person in the community would provide that. So, but we didn't have trained nurses until the mid 1800s. Along with professionalization of physicians, which we've talked at length about. So then we see kind of as we progress towards, towards the present, advanced institutions for training and research. So we saw this consolidation of teaching hospitals, creation of teaching hospitals that provided training to physicians and nurses and other kinds of professionals. So some of you are going to be doing internships, and I know a bunch of you are nutritionists, so future nutritionists, future OTs. I forget what else you could, but those of you who are going to be clinicians will most likely be doing some portion of your apprenticeship style training in an institution, like a hospital, like a academic medical center, most likely. And then, we saw the explosion of private health insurance in the 20th century, and this provided the resources that that allowed the further development of healthcare delivery. But notice that stage, that provision of private health insurance, only happens relatively late when income is relatively high. Right, relatively speaking, income had to rise to a relatively high level before we could afford to have healthcare. So one of the things that you should consider, and we talk a lot about how expensive healthcare is in the United States versus other parts of the world. Bear in mind, the United States is also the richest country in the world per capita, right? One of the richest countries in the world, setting aside like some tiny, Luxembourg or someplace like that, that has 500,000 people. And when we talk about, large countries like the United States, 340 million people with a GDP per capita of pushing $50,000, we are by far the wealthiest country in the world, and we can afford to spend more on healthcare than anybody else can. Which is part of why healthcare is so expensive. So I want to kind of replant us there because we'll talk about the institutions of the hospital a little more today and medicine to say, for most of human history, we didn't have hospitals. We had kind of some sort of community-based care, everything from, witch doctors that I talked about at one point to, there are long traditions of almshouses and places that were provided, again, by the wealthy, typically in a community for kind of their own self-aggrandizement, right? So you got status by starting up some sort of facility, some sort of institution to take care of the poor and the sick. It gave you social status. So you use some of your money to do that, and it gave you social status and kind of helped to secure your position. All right, so 6 major things that your chapter talks about. I'm going to focus on 2 of them in these lectures. That is specifically advances in nursing and the emergence of the federal government and its role in delivery of care. The other ones we've kind of talked about already at some length. The chapter goes into more detail about it. But I think these are the 2 things that I really want to spend some time talking about, and you can get the rest from reading the chapter. So nursing, like, a lot of other institutions, nursing was an undifferentiated institution when I talked about it before, right? So anybody could be a nurse up until relatively recently. There was no such thing as a licensed nurse, just like up until relatively recently, anybody could hang out a shingle and say they were a physician in the United States. So relatively recently, meaning 100 or 120 years or so. Licensing nursing is more recent than that even. So it followed behind physicians. So this is a picture of Florence Nightingale. So Florence Nightingale was born in 1820 in Florence, Italy, to a wealthy British family. And she should have, had she followed kind of standard her life, her life's normal fate, she would have been a wealthy socialite, going to tea parties and marrying some wealthy, other wealthy British dude. But instead she decided that her real calling was nursing, and decided to kind of break with that and chose kind of this professional training. And there was some professional training available at this point, but like most of medicine in the mid 1800s, it wasn't particularly effective, right? And we knew relatively little about what effective nursing was, but she was very quickly recognized after finishing her training, very quickly recognized for her talents, and rose to be the superintendent of a hospital in London, at a relatively young age. And then we had the Crimean War. So we've got, once again, Russians causing trouble in the Ukraine. This was at this point, Great Britain was at war with Russia, and Florence Nightingale, feeling called to her nursing mission, went to the front to provide care to British soldiers and reported back on the conditions that the wounded were being treated during this period. And she was shocked by how bad the care was. So people were dying of all sorts of disease, which is I've mentioned this before, the most frequent killer of soldiers was not up through the Vietnam War. The most likely, if you were a soldier, the most likely way you were going to die was not from being shot or stabbed by the enemy, but instead most likely by cholera or dysentery. So you are more likely to, or the flu. So you are more likely to die of some disease, some awful disease, highly communicable disease, than you were to die from actual wounds from battle. So Florence Nightingale went, so this is a painting of her treating wounded soldiers, and went to the Crimea and treated, there were some 18,000 soldiers languishing in military hospitals. The conditions were terrible, and soldiers were dying in particular from diseases that are basically diseases of filth, cholera, dysentery. Right? You get cholera and dysentery from drinking water. The most common way to get cholera is through drinking water where the bacteria has infected the water. You get it from from being in contact with other people's waste. So bear in mind, no indoor plumbing in the 1850s, right? So you're talking about, and if you're talking about a camp scenario, you've got people who are, you'd be lucky if you have an outhouse. More likely, you're just going to the bathroom out in a what we call a slit trench, which you dig a trench and everybody does their business in the slit trench. You try to keep it at least in one place. So these are not attractive things, but this is not an attractive time, right? And so Nightingale goes there and sees the men living in squalor, and implements her main thrust of her work was to implement sanitation. So this is a critical thing, to implement sanitary steps. So she focuses on cleanliness, right? And providing the patients with clean sheets and to the best that you can provide in the conditions. And this has a very powerful effect in terms of reducing death due to what we call non-battle injury or illness, disease or non-battle injury, DNBI, disease and non-battle injury. So the men of the British Army, she became a bit of a legend because she was tireless in her care for the men in her care, and often was seen walking through the wards at night carrying a lamp, and became known as the lady with the lamp, and for her caring. And so today, nurses, when they get there, when a nurse graduates, they go through a pinning ceremony, and one of the most common pins is pictured on the left. It includes an image of a lamp still today. So Florence Nightingale is considered kind of the founder of modern nursing, and the lamp is her symbol, and it's still used by nursing programs today. So after the war, she returned to England and worked with the military and campaigned to improve military medicine and nursing in general. And she relied on statistics, which was a relatively new thing, right? So coming back to the idea of using reason and science, right? Statistics was a relatively new tool that was available to healthcare and to people who are trying to make improvements. So if you want to make an improvement, you have to be able to measure it. So statistics is the tool that we use, right? It's the mathematical tools that we use to measure where are we and where are we trying to get to, right? And if we apply, if we apply a treatment, does it make does it make a real impact? So she was a founder in the sense that she identified, much like Semmelweis and the story I told you about the obstetrics hospitals that he worked in, and the idea of washing hands. She's from about the same period, and she was implementing those aseptic techniques more broadly across the hospitals. So she came up with a number of different approaches to reduce disease and disease transmission, which again is the number one killer of soldiers. And she did it using statistical techniques. So she was a real innovator in that sense. In 1859, she publishes, so this is not 5 years after she returns from the Crimea, she publishes a book, Notes on Nursing, what it is and what it is not. Pretty straightforward, right? This becomes a foundational text for nursing education in this period, and is, and is used for a number of decades after. She founds the Nightingale Training School at St. Thomas's Hospital in London, and then by 1873 we have 3 Nightingale schools of nursing in the United States, including one at our own Mass General, right down the street in Boston. So this is a beginning of a formalization. So this is the formalization of nursing training happening. So up until now, right, up until then, up until Nightingale begins to formalize nursing training in the 1860s, anybody would just be a nurse. Just find some, most likely some relatively poor working class woman and say, I need a nurse. Okay, I'll be a nurse. I've, taken care of kids and I know how to put a bandage on. I'm a nurse, right? So that was kind of what we had for nursing up until Nightingale began to, formalize what nursing is and what it is not, right? Hence the title. So by 1900, we have more than 400 nursing schools in the United States. So the nursing as a profession begins to emerge in a more formal sense. And so early nursing schools were primarily apprenticeships. You would, their nursing school was co-located with a hospital. So at Mass Gen, you'd join the nursing school and then you'd go into the hospital and work as a nurse, and you learn on the job, right? By following around a more senior nurse who teaches you, all right, this is how you make the beds, this is how you wash the sheets so that they, are sanitized, this is how you wash the floors, and it's pretty basic stuff, because nursing at this point was pretty basic, but it was, but it was a leap farther than what it had been. And so we also begin at this point in the late 1800s, early 1900s to see states beginning to have occupational licensing. So much like physicians, like I said, up until relatively recently, you could just say, yep, I'm a nurse, I'm ready to go. And you could start providing nursing care and maybe not hanging out a shingle per se, but going out into the community and practicing as a nurse. So much like physician licensure, nurse licensure is also at the state level. So we've talked about this. Economic licensing is under our federal structure. Economic licensing for any profession is done at the state level. So if you want to be a nurse, a doctor, if you want to be a barber, an interior decorator, all those licenses are done at the state level. We don't have federal licensing. So it takes time for the states to decide, okay, this profession has arrived at a point where the skills are discernible from just any average, working class person. And so So we start to see state by state licensure coming into effect, and that's typically how we see it. So we have somebody wrote their paper on Stephanie Nadolny, who was a vice president of a rehab hospital, and she went to UNH, got her degree in rec therapy, which is a really cool field, by the way. So if you're still looking for a major and you're thinking you want to work with patients, but maybe you don't want to, be a physician or a nurse, rec therapy uses activities of recreation as forms of therapy. And it is not a licensed profession in all states in the United States at this point. So some states you can just go show up at a hospital and answer a call for, answer an application for rec therapists, and they'll be like, well, what was your experience? Oh, I used to do recreation management in a nursing home. And they're like, okay, you can be one of our rec therapists. In about half of the states in the United States now, you have to go through a program like what we have here at UNH, get a degree in rec therapy, do an internship in rec therapy, and then pass a national board to become a licensed rec therapist. My point is that's not yet true in every state. So some states you can just show up and say, hi, I'm a rec therapist. In some states, if you have to show up and show your credentials in order to say that you're a rec therapist. So the same thing happened with nursing. So through the 20th century, we see kind of professionally early 20th century, so the late 19th century, early 20th century, if you went through one of these Nightingale schools, when you graduated, most likely there was a waiting list of wealthy families with elderly or sick or invalid family members who were looking to hire you to work in the home and take care of their family members. And that's where most nurses went. You didn't stay in the hospital. That was regarded as kind of lower status. So it was much higher status to be taking care of family members in the home rather than in a hospital. So it wasn't until the 20s and 30s where hospitals began to really become the hub of healthcare delivery that professional nurses really started to stay in the facility in hospitals. So nursing and since then, nursing continues to evolve, right? We're seeing more and more specialization. So back, we had, I would call Nightingale's early stage of training vocationally trained, right? Vocational nurses. What we saw as registered nurses or RNs became more and more common. They began with roughly like it used to be a 2-year program. So it was basically like the equivalent of an associate's degree. And there was a mix of kind of classroom training and applied training. It's always been a lot of applied training for nurses. And if you see our students in our nursing program, I don't know if, has anybody in the nursing program? I forget. Okay, at least one. All right. So you'll do a lot of clinicals, right? You have to go out and do rotations in a real hospital, in a real nursing home to learn your trade. They have this really cool laboratory. If you're ever, been moved down the hill to the new facility now, the lab with all the patients. They've got these awesome dummies, training dummies that you can do all kinds of things to them. And an instructor can like be sitting in like behind a mirror. They have them like a mirrored wall or a mirror, one-way glass, and they'll be sitting back there. And you go in to be, as a nursing student, you go into like, you can take blood pressures on these dummies. And what else can you do? Can you give them IVs? Some of them you can give them IVs. I mean, some of these are designed, you can practice delivering a baby on them. It's really crazy. What else do they do? What have you? Okay, so you can yeah. Okay. Sure. Right. So they're, they have the old like Resusci Annie that, that I worked on when I, got my CPR certification, but you can go in with your stethoscope and listen to their heartbeats, and the instructor can, sitting in behind this one-way mirror, can change the heartbeat on you. And, when you're talking to you have to, like, this is meant to be practice. So you go in and you're supposed to talk to the dummy like it's a patient. Right. And then the instructor who's sitting, in the other room is like talking back to you, and giving you clues as to what might be wrong with it. So it's really amazing technology. But this is an evolution, right? So we've seen nursing kind of typically was a 2-year degree, then it became a 3-year degree. Now it's mostly a 4-year degree, relatively few 2- and 3-year programs. And those 2- and 3-year programs used to be like the original, like Nightingale program, where it was out of a hospital. They're becoming more in university settings, like our nursing program is. But you're seeing that evolution as we're seeing more and more education is expected of RNs, and you're seeing most hospitals today won't hire you if you don't have at least a 4-year RN degree. So nursing roles continue to get more and more complex. Some of you wrote about nurse practitioners, right? And you've had exposure to that. So from the nursing science, the nurse practitioner is a high-level advanced practice nurse. So APN, advanced practice nurse. But we have other kinds of APNs that we have nurse midwives that have their RN, and then they go on to get a master's degree in midwifery, where they learn how to deliver babies and care for women through pregnancy. And there are other types of specialty. So nursing really continues to be very institution-based, meaning it's still very much an inpatient-oriented, hospital-oriented discipline, but we're seeing more roles in outpatient. So specifically, the family practice nurse practitioner or family medicine nurse practitioner is a great example of a primarily outpatient advanced practice nurse, right? So your family practice or family medicine, they don't like to be called family practice. They like to be called family medicine. Family medicine nurse practitioners rarely function in a hospital, though they can, right? And you see all sorts of different specialties within nursing. So you have your basic med surg nurse, which is kind of most likely what what most young graduates go to do. You go to a med surg floor, a medicine floor, a surgery floor, right? To kind of learn your skills and finalize your skills. And most hospitals have sort of a postgraduate internship program for new nurses. So that first year you are on the job as a new nurse, you have a preceptor, and they're kind of finishing your skills, developing your skills. And so that you continue to learn, you continue to kind of that apprenticeship learning in that first year. And then after that, after you kind of achieve basic level of competence, you can specialize. So you could become an OR nurse. So OR nurses are a specialized kind of type of nurse that understands the procedures in a operating room and all the tools and the risks that face a patient who is having surgery and is under anesthesia and so forth. You have nurses that go on to ICU training. So you do, so they specialize in ICU. The biggest thing with ICU is managing airways. So, usually wind up in the ICU if you have a likelihood that you won't be able to breathe. And so, ICU nurses kind of have a high level of training in monitoring the very ill. You have ED nurses, right? So nurses who kind of specialize in the ED environment. And so what you see is a lot of kind of specialization based on environment. So the ED environment is different than the ICU, right? The ED environment is you never know what's coming at you next. With the ICU, you have a pretty good idea. The person is in the ICU because they have a particular medical condition. And so you're managing that particular medical condition. Whereas in ED, you just never know what's going to walk through the door next. Trauma nurses. So these are kind of high level ED nurses. They're, specialized in taking care of patients that have been in major car wrecks or major accidents. I remember I went through, when I did my initial training as a medical service corps officer, we went through this thing called Officer Basic Course, and we were doing some trauma practice, dealing with biological and chemical injuries. So the Russians, back when I joined, they were still the Soviets, were very fond of using chemical weapons and biological weapons. So we did a lot of training on a lot of our training we did in chemical suits. So we had these big kind of bulky chemical suits with masks, and so I remember doing some training like that, and we were running a drill, taking care of a patient who had been injured during a make-believe chemical attack by Soviet bad guys. And so we had the patient, the patient came in, and mock patient came in, and we had to get him out of his, we had to decontaminate him and then get him out of his chemical suit. And they gave us, these trauma kit, these scissors. So guys like me with like zero medical, zero training in such skills. And we're like, you just, if you have somebody who's wounded and you need to take care of them, you're not going to worry about saving their clothes. You're just going to cut the clothes off of them. So you take these big heavy scissors and you just start, working your way up their pant leg to just rip the pants off them. And, me and a couple of other folks who were, future administrators were like struggling with these scissors, trying to, get the pants off. And there was I'll just never forget her. She had been a trauma nurse in real life prior to joining. So she had been a nurse, had been in practice for a number of years. She was probably in her mid 30s. So she'd like 10 years of practice. She was like, get out of the way. She grabs the scissors and just goes right up the pant leg. And we'd been like wrestling with it. And she just made it like, it was like she was cutting through butter, and it's just a skill that you learn, so that's what the trauma nurse contributes in that environment. Like the trauma physician isn't going to be doing that. That's, so the nursing, the job of the nurse in that situation is to prepare the patient so that the physician can work on it. So it's to me, that was like one of those, like, holy cow, there's, some real skill and knowledge there. But it's unique. So, so we have ICU, trauma, ED, and then they have community health roles. So we have nurses that also work in public health, tracking down, in our current situation, tracking down contagious disease, but a bigger, probably a major role for nurses since the 90s is, tracking down sexually transmitted disease, AIDS, huge issue with AIDS back in the 80s and 90s, right? So there's just all these interesting roles that nurses have evolved into. So you start with kind of the basic RN, and then there's all these different kind of specializations that they can go on to do. Some require additional degrees, some just require experience. Okay. So that's nursing. And we'll have, like I said, I'm inviting Eileen Keefe to come in, Zoom into class on Thursday. Eileen is, like I said, Eileen is great. Her daughter graduated from HMP 2 years ago now. So I've gotten to know Eileen through that. So kind of nursing was one of the 6 things that this chapter kind of covers. The chapter goes into more depth on a lot of other stuff, like, the medical training and so forth. We've already talked about a lot of it, so you'll just deepen your knowledge there. The federal government, even though we are organized as a federation where states are supposed to manage economic activity. The federal government since the 20s we have seen a increasing role of the federal government in almost every part of economic life. Healthcare is not excluded from that. In fact, you see a lot of it in healthcare, even though we still see state level licensing and things like that. So how has the federal government been involved in the growth of hospitals? Well, up through World War II, right, up through the New Deal, the federal government was relatively weak. One of the things that made it weak was the federal government didn't have great sources of funding. So the 16th Amendment to the Constitution, which was ratified in 1913, created the federal income tax. Yay. My wife is a CPA and she's a tax accountant, so she's deep involved in processing tax returns right now. But it wasn't until 1913 that the federal government had this very powerful tool, the income tax. Prior to that, the federal government was funded by various fees and tariffs, right? So it made money by taxing certain things. So it had relatively little money to do anything with. And so it was kind of hamstrung in terms of what it could do because it had few resources to do it, which should sound, at this point, in the course, we keep hearing that, right? It's all about resources. It's all about money. You can't do anything without money. And so the federal government became had much more capability once it was allowed to tax. So that was a major turning point, kind of 1913, you're around World War I, right? And the federal government, once it has a tax, it almost never gets rid of it. And so that tax, and initially that tax was passed as just a tax on the rich. So we're going to soak the rich. And it was a very small percentage. So most of us wouldn't have been hit by that tax back in 1913. And so just let that be a warning. Whenever you hear, we're just going to soak the rich a little bit, just take a little bit from them, to give it to the rest of us. Just remember that that's just, as they say, the camel's nose under the tent, right? It kind of pokes its nose up under the tent, and then pretty soon the whole camel's inside the tent, right? So the federal government begins to kind of become a, more and more centralized power in U.S. politics, especially through the New Deal. Lots of economic regulation comes out of the New Deal. And one of the things that the government decides is that we need to have more hospitals. So they pass the Hospital Survey and Construction Act of 1946, better known as the Hill-Burton Act. And the Hill-Burton Act starts to allocate federal funds to build hospitals, which was kind of a new thing because prior to that, the federal government didn't have a role in building stuff in states. That was a state function. So now the federal government, with its ability to tax, its ability to generate a lot of income for itself, starts using that income to do things like building hospitals, which is, a good idea. If you're going to spend money, building a hospital is not a bad idea if you're going to spend that money. And they set a goal of having 4.5 community hospital beds per 1,000 people in the civilian population. So bear in mind, 1946, most people still lived in rural communities. Most of the US population was still rural. Today, most of the US population is urban or suburban. So we started seeing a lot of hospitals being built in relatively rural areas, which is a good thing because, if you were a farmer, you didn't have access to the healthcare that was at this point in time beginning to, actually work. And it was all centered around inpatient care. And so if you didn't have a hospital, you didn't have access to quality care. So that was the logic. We needed to have more hospital beds per per civilian population so that we could get our population the most advanced care. So they set this goal of having 4.5 community hospital beds per 1,000 civilian population. We did finally reach that goal. So from 1946, it took us till 1980 to reach that goal. And so it helped kind of subsidize about 40% of the new beds that were built in the United States, even in the most remote areas. So you can, and you can make an argument about whether that's a good idea or not, to subsidize anything. But, if you build a hospital in a rural area, it makes it more pleasant, more livable for people to live in rural areas. The alternative that I like to say is the alternative there would be to subsidize people leaving rural areas, right? Because, if there's no economic activity, if you're poor because there's no jobs, it doesn't really make sense to just give people cheap services so that they can keep living in an area that doesn't have any economic activity, because they're always going to be poor. They're always going to be dependent on government handouts. So, it's hard to tell somebody, hey, the place where your family has lived for the last 5 generations, it doesn't make sense to live there anymore. You should move to Boston. Is a hard thing to tell people. They'll lose their way of life. They lose the community that they're part of. So you're always going to see some tension there. But I'd like you to think about that, at least as there's an element of justice in the sense of these are Americans and they should be taken care of. On the other hand, there's no economic reason for, if your community is poor, one of the best things you can do is leave, right? The problem is if you're poor, it's hard to leave. And so instead of subsidizing services so that people stay in a poor community, an alternative would be find ways to subsidize people finding new jobs, moving to new communities, help them get settled in new communities. So that's kind of here and there, a different perspective. So in addition to that, in addition to direct subsidies to building hospitals, Medicare and Medicaid programs suddenly gave resources to people, the elderly and the poor, who would not have been in the past, wouldn't have been able to afford healthcare. So suddenly the elderly and the poor had a lot more resources that they could spend on healthcare because the federal government is giving it to them. And you can only, if it's Medicare, it's not like you can take your Medicare benefit and go buy a new car, right? All you can do with your Medicare benefit is buy healthcare. Well, that now provides income to people who are providing healthcare. And so it becomes, so then we see entrepreneurs, physicians, hospitals being built to take advantage of the fact that suddenly people have money to buy healthcare. So you had direct subsidies through the Hill-Burton Act to actually build hospitals. And then you had money going to potential patients who could only spend that money on healthcare. So then you could, if you were an entrepreneur, you could say, hey, there's a whole new market of people who prior to the implementation of, prior to 1965, wouldn't have been able to buy care, but now they can. And so that was another surge, caused another surge of kind of came together in terms of creating the surge of building. And rural populations are older and poorer than urban populations are on average. And so this had a dramatic effect in terms of creating a pool of resources in rural communities. So coupling that with the emergence of private health insurance, hospital insurance starting, and we talked about this, right? Hospital insurance starting in the 1920s, that, at the Baylor hospital system, evolving into Blue Cross, Blue Shield coming out of that to pay for professional services, all that stuff, right? Emerges. So today, it's common for healthcare organizations to get somewhere between 30 and 60% of their revenues from a combination of Medicare and Medicaid. So this is a major impact, right? If 30 to 60% of your revenue comes from the government, that's a major player. If you imagine just deleting that, you would have to shrink your organization dramatically. So here's an example of a real hospital. This is what we call a payer mix. And this is really, really important to hospitals, because what it represents is the mix of how the patients pay for their care. So in this case, they've got they've broken out their revenues into 4 components. They've got, or 4 types of payers. They have private payers, which are commercial insurers, Blue Cross and Blue Shield, think your Cignas, all that. Then you've got Medicare, Medicaid, and self-pay. Self-pay means I don't have health insurance, either because I'm super rich and I don't need it, or I'm too poor to have health insurance, in which case, I show up to the ED, ask for care. We can't turn you away from the hospital. So we put them in the self-pay category. That category of patients, which makes up the bulk of the self-pay patients, are basically charity, right? They become basically charity care, meaning we don't think that somebody who is too poor to have insurance is likely to pay their hospital bill, right? So, and then the amount that that patients pay through their payer is basically in this order, in descending order. So private pay patients who, private payer patients, so patients who have commercial health insurance, pay the best, right? They have the highest reimbursement per discharge or per service, followed by Medicare, which has dramatically worse levels of payment, followed by Medicaid, which is the worst of the payers, and then followed by self-pay, which usually means you're not getting anything. So this hospital, which is one of our local hospitals, gets about 37% of its revenues from Medicare and Medicaid. So it's a major impact on their organization. If you think about, so that's a lot. I will tell you that's a lot, but this is a relatively wealthy hospital. If you go to poorer communities, you'll see the payer mix shift towards something more like 50 or 60% of revenues are coming from Medicare and Medicaid. So again, who would you rather have as a patient? Would you rather have a patient with commercial insurance that pays really well, or would you like to have a bunch of old or poor people who have government insurance that doesn't pay as well? And the obvious answer there is, as a hospital, you'd rather have more private pay because you're going to get more resources when you provide the care. Now, most hospitals, we'll talk about this in a minute, most hospitals are nonprofit charitable hospitals, right? So Wentworth Douglas is a nonprofit charitable hospital. Exeter Hospital is a nonprofit charitable hospital. Catholic Medical Center out in Manchester is, the Elliott is, right? Dartmouth Hitchcock is, Mass General is, right? Portsmouth Regional is not. Portsmouth Regional is a for-profit hospital. Frisbee, I forget what they call it. Frisbee Hospital is a for-profit hospital. They are part of the HCA hospital chain, right? So payer mix is a really important thing that hospital leadership pay attention to, because if you get a bad payer mix, you are going to have to become much more efficient about providing your care. You might have to dial back on quality. You might have to make decisions, right, to provide lower cost, lower quality care. I did one of the podcasts, nobody chose it, but I did a I did a podcast with a student, a former student, who wanted to who was interested in going into dental school, and we interviewed the director of the dental program at an FQHC, a federally qualified um, uh, health clinic. So this is a provider of last resort, a FQHCs provide care to people, to anyone and everyone who comes through the door, regardless of their ability to pay. So these are clinics that provide care to people who can't afford health insurance, people who are on Medicaid, and so forth, who can't, so Medicaid, a doctor can say, no, I'm not taking, if you have Medicaid as your insurance, I'm not taking you as a patient. So a lot of people who have Medicaid have a hard time finding a physician that will take them. So FQHCs take them. Well, this FQHC also, it was Families First in Portsmouth. They had a dental program. Not all of them do, but they had a dental program. And the gentleman who ran the dental program was a retired dentist, did it for free, provided care for free. And one of the things that kind of, I didn't know, but it makes sense, and it's shocking to hear it though, is he takes care of a lot of homeless people, right? So the homeless around Portsmouth and Dover would come to Families First to get, if they had some sort of bad situation with their teeth, he'd see them. And so I have, not proud of this, I have like 3 crowns. I don't know if any of you have, hopefully none of you have crowns yet. But if you don't do a good job of taking care of your teeth, you don't do a good job flossing, you eventually get a bunch of cavities, and and they'll put in, they'll drill your teeth and they'll put in, fillings. Eventually your tooth can only take so many fillings, and those fillings get too big, and they have to put a crown on, which is basically they grind your tooth down to a stub. And then they first make a cast of your tooth. Then they grind your tooth down to a stub, and they use the casting to create either a gold or a some sort of composite crown that sits on top of the stub that used to be your whole tooth, right? And they put that on top. And that's a way of saving your tooth, right? Because otherwise they'd have to pull your tooth. That would be that's the alternative. So talking to this dentist, again, volunteer, if he had a homeless patient come in with no ability to pay, generally speaking, what they would do is, if they had a situation that would call for a crown costs, so I just got one, cost almost $2,000 to get a crown. So if you're homeless, you don't have $2,000. I mean, that's kind of, if you had $2,000, you wouldn't be homeless. So they extract the tooth instead, right? It's still a standard of care, right? This is it's an appropriate treatment, because otherwise, if your tooth is diseased enough that it needs a crown, but you don't have the resources to put a crown on it, the standard of care is to extract the tooth. So they pull the tooth instead, and pulling the tooth costs $25, right? So that's the nature. So I tell that story because if you are resource constrained, the appropriate, the kind of care that you can afford, the kind of care that will be provided to you, will not be the same as if you are a wealthy person, right? So hospitals that have a bad payer mix are going to have to make choices. That's an oversimplification, but they'll have to make the equivalent choices of, do we do a crown or do we extract? I could see the variation there would be, do we use the latest titanium implants for orthopedic surgery, which are very expensive, right? Titanium, very light, very hardy. Or do we put in do we put in a titanium? You need a hip replacement. Do we put in a titanium hip, or do we put in a steel hip? Steel hip it works. You'll be able to walk, but it won't last as long. it's not as good a quality of care, but it's the standard of care. You can do it. But if you're talking about resource constraints, you're going to make the choice between cutting edge and kind of what's the minimum level, right? So that's where payer mix becomes really important. And bear in mind, if you're sitting there thinking, well, in Europe, they wouldn't do that. Yeah, actually they would. Everybody would get a steel hip in Europe, right? Nobody gets titanium. That's not true. I mean, but that's the equivalent, right? In order to save money, they don't do the top end of care. If you go to Mass General, if you can afford to go to Mass General to get your hip replacement, you're getting a titanium hip, right? If you get your hip replaced in, some rural hospital in Great Britain, you're getting a steel hip because it's cheaper, right? And it works. And that's how they save money. And that's similar, hospitals in the United States make similar decisions based on the ability to reimburse. All right. So we've talked about the story in the 1980s, right? So finally in 1980, we hit 4.5 beds per 1,000. And then in 1982, we passed the Tax Equity and Fiscal Responsibility Act, TEFRA, which implements PPS, which we've talked about at length already. And what happens when we implement PPS? What happens to inpatient care? Nope. It starts to collapse, right? We go from cost plus, right? That's what we had before, was cost plus reimbursements. We have all these new beds, very exciting, very new, very space age, right? That was a thing back in the 60s. We all wanted to be space age. The cars looked like rocket ships, right? Everybody was trying to be space age and, very exciting. We were very much sold on science. If you think you heard follow the science enough times on social media, you didn't hear nothing like what they used to say in the 50s and 60s, right? Science was like the god, right? And so everybody wanted to be space age scientists. But the best care was happening in hospitals. So everybody needed a hospital. Then we realized, oh my goodness, this healthcare stuff is really expensive. And we passed this, Medicare, Medicaid in the 65, and we've already talked about this, healthcare spending goes nuts, right? And so they pass TEFRA and create PPS to try to start reining in costs. The direct effect of that is we're going to compensate you, hospital, not on a cost plus, this is review here, not on a cost plus basis anymore, but a fixed fee per DRG, right? So we're going to find you diagnostic related group. We're going to say, okay, physician, you've admitted so-and-so for a hip replacement. Hip replacements get $20,000. Hospital, figure out how to provide that care for less than $20,000. Congratulations if you can do it. If you can't, too bad, so sad. And what happens very rapidly to do that is if you got a hip replacement, you probably have been I'm going to make this number up, but you probably would have been an inpatient for 2 weeks, to get your therapy and care, right? Well, we could do that when we could bill $500 a day for the hospital, stay. You could bill $10,000 for the surgery. We could bill all this stuff, and then we just send the bill to Medicare or send the bill to your insurance company, and we'd get, we would say, hey, it cost us $25,000 to provide this care. They would say, okay, we're going to give you 5% on top of that, so you get, now that, of course, I pick a number I can't do 5% of in my head, but you'd get 5%, 105% as your fee back. Then we switch to PPS, and we say, we don't care what you spent. Don't tell us. We don't want to know. You're getting here's a check for $20,000. Find the way to do the care. Well, suddenly that 2-week stay for a hip replacement collapses down to 2 days, right? Down to 1 day now. Most people are in and out of the hospital in a day, right? You're in the hospital, out of the hospital, either discharged to home where you have a home health agency taking care of you, or you're discharged to a nursing home where you get a higher level of rehab, but it's a lot cheaper than it being in a hospital. And so hospitalizations collapse from, 7 or 8 days on average to like 3 days on average, right? So you suddenly see this shortening of days. Well, if people are staying in your hospital for fewer days, you don't need as many beds. I had a great conversation with Kevin Callahan, who's the CEO of Exeter Hospital. He's been the CEO of Exeter Hospital for like 38 years or something like that. So he came in right around the time that that this was about to happen. He started his career in the 70s. He guided Exeter Hospital was a 100-bed facility, right? Pre-PPS, and it's still a 100-bed facility. It didn't grow. A lot of hospitals during this period of Hill-Burton took advantage of federal funds to increase their number of beds. Exeter chose not to increase their number of beds and was able to manage and stay in place. So a lot of hospitals that increased their number of beds, or hospitals that were started with the assumption that you'd have 7 or 8 day long on average length of stay admissions, suddenly found themselves shrinking from long lengths of stay to very, very short lengths of stay. And you just don't need as many beds. You need like 60 or 70% fewer beds. I'm friendly with the CEO, I've mentioned before, Mike Peterson. He's the CEO of Androscoggin Valley Hospital up in Berlin. Beautiful hospital, built in early 80s, I think. So it's a beautiful hospital. It's huge. It's a 25-bed hospital now. It's a critical access hospital. It's got 25 beds. It was built to be a 100-bed hospital, right? So it was built right as this was happening. So the architects were like, oh yeah, we have 7-day, 8-day lengths of stay. So we're going to need 100 beds for a community of this size. Well, a couple of things happened. One was PPS. Two was, if you know anything about, the North Country, Berlin used to have a bunch of paper mills, and the paper mills all closed, or most of them have closed or consolidated. So Berlin lost its main source of industry. Simultaneously, right after they build the new hospital for 100 beds, this happens where, suddenly our average length of stay is shrinking. And then on top of that, they lose their major source of industry, major source of economic growth. Much of the population leaves, Berlin. So now you have a population of 10,000 people with a hospital meant to serve it that was built to have 100 beds, now has 25 beds. That's a common situation across the country. And what we saw was huge numbers of closures because hospitals just couldn't manage it. They couldn't manage this new way of being reimbursed. And so we saw hospitals collapsing the number of beds, and then also just not being able to stay in business. So we saw a huge number. So we finally hit the goal of 4.5 beds per 1,000. And we immediately changed our policy and caused a retraction of the number of beds. But that said, if you're admitted to a hospital, there's typically something seriously wrong with you, right? Or they're concerned that there might be something serious. You might be admitted if you have a head injury. They might admit you to observe you, because it's hard to know with a head injury if something isn't going to go wrong. So stays become shorter and more intense. All right, we'll stop there. We'll pick up with this next time. When we come in, I think the plan is to have Eileen talk right at the beginning of class. Then we'll finish up with the slides after she chats. All right, see you on Thursday.